So welcome to this week's Precision Podcast, and I'm joined today by Lou Morgan. Lou is an Advanced Nurse Practitioner. Am I right, Lou?
Yes, you are.
And we connected with one another on our yoga training course, didn't we?
We did, yes, yeah.
So we're having fun with that.
Yes.
It's a lot
better now we can see each other properly.
Oh yeah, exactly. It's much better now we can be together in the flesh, although tonight we're not, are we? So Lou and I were talking about the fact that we both had an interest in pain management, pain, how the body reacts to pain, and things we can do to help people who are living with pain, perhaps for prolonged periods. Even short-lived bouts of pain can be really quite disabling, challenging, can't they, Lou? So you were telling me your background was actually in emergency medicine.
Yeah, most of my career has been urgent care or emergency care in various different places. So my experience of pain up until sort of recently has been acute. So acute trauma, heart attacks, those kinds of things where people come in acute distress. We did used to have lots of people who would have a chronic pain problem, be it back pain or arthritis, who would then have an acute flare-up, so an acute on chronic flare-up. So their pain kind of needed managing promptly, still, but paying attention to the sort of the underlying management that they were already receiving. So it's a very different situation to what we deal with now, which is more chronic pain, long-term pain, and a lot of it is neuropathic pain, so nerve pain, arthritis, and those kinds of conditions.
That in my experience, the neuropathic pain is the one that people really struggle with, isn't it?
I think because it's such a difficult pain to describe, and you can't really see it. If you've had a trauma and broken a bone, there's something that needs fixing. There's a reason for the pain. Yeah. At the time, the neuropathic pain is as a result of something else. So the back pain patients that we see have got a back pain issue, but their most significant pain is in their legs. And it's a difficult thing to understand that there's nothing wrong with the leg, or there's nothing wrong with the nerve in the legs necessarily, but the nerve in the back where it comes out of the spinal cord is what's irritated, and that gives the nerve pain through the entire nerve pathway. So it's sometimes very difficult to explain to the patient, although this is back pain, their foot is painful. And it's a very strange pain, nerve pain.
Oh, that's right. Yeah, people describe all sorts of weird and wonderful sensations like ants crawling and burnings. Burning's quite a classic symptom. We said neuropathic pain, and for those people who are not sure, nerve pain was what we were talking about, wasn't it? Yeah, all kinds of weird and wonderful sensations. Sometimes people feel like the limb feels bigger, or lots of fascinating to us. It's not fascinating.
It's not fascinating for them. No. It's that sensory feeling. I think that's why people can describe it in so many different ways, because it's the way they sense the pain, and everybody senses things in a very different manner.
Well, that's right. And so this is where signals are open to interpretation then, isn't it? That these raw electrical signals then pass through the grey matter, between the ears, and then it's open to interpretation. Our own cultural experiences, our upbringing, and our history of how we've had pain, dealt with pain in the past. All of these things go some way to influence how an individual will experience their own symptoms. And you and I were saying it's fascinating. I mean, it is fascinating to us. We're interested in this area, but obviously that's no consolation to somebody that they're fascinating, is it really?
No, they don't want fascinating. They want.
No, they don't.
They want, fixing.
Fixing, not fascinating.
Yeah. But a lot of people are quite astounded when you try to explain to them about how the nerves detect pain and sensation, the link to the rest of the body, and how the brain has to interpret what it's feeling and act on those feelings by engaging muscles, and you know, that impacts on everything else in the system. So it's all encompassing, really. When you talk about mood and sleep with a patient, they kind of didn't realize that it all has that impact. So their mood lowers, their sleep's not very good, their pain is worse, and so everything is really kind of linked to the nervous system and how they sense their pain, and what makes it flare and worse.
That's right, and so even emotional experiences can cause or trigger episodes of increased intensity of pain, or you know, you know, as we say, fascinating. But I think this is the thing that I've found in my work as a physiotherapist, that it's really important how each individual's experiences are so unique, and therefore the way in which we deal with these individuals should be tailored and unique, and that's not always easy, is it? You know, for sure.
No, and I mean, when you assess a patient, it's about talking to them about their entire history, all aspects of their life, because it needs to be an individualized treatment plan, or a program of rehab or treatment, whatever you want to call it. Mm. Everybody looks at it slightly differently. So we take a really in-depth assessment. They're talking about their sleep and their mood and their social activities and their family support and mental health history, their past medical history, all those kinds of things, all will sort of influence the way you start to manage the pain. And a lot of our work is looking at self-management and holistic therapies, not necessarily medicines and injections, because we know they don't work. So it's looking at what we can do for the patient to help them manage in their way. So everybody is very different. It's a very individualized plan. And
yeah, I mean, and that's entirely appropriate, isn't it? You know, this is something that maybe if they'd had this approach sooner along the journey, you know, people might somehow, we might avert this continuation to chronic pain, really, I suppose, is the thing, isn't it?
And there are a lot of patients who've already started to look at those kinds of more holistic things, people that do Pilates, yoga and walking and cycling and swimming, and you know, they seem to manage a lot better and have a better frame of mind with regard to how the pain is a total body experience and not just a painful foot or a back pain. And so they tend to be the ones that are more engaged, are more successful really at managing their pain, the ones that have already started to think, actually, this is more what I need to do, than some of the patients who are frightened of moving and frightened of doing anything because there's a fear that I'm going to make this worse, or because pain is generally there as a threat system to warn us that there's something wrong. In chronic pain, there isn't anything wrong really. The software's gone wrong and is malfunctioning, but actually physically there's nothing that you're going to make worse, and there's a fear factor, I think, that goes with some of that.
Yeah, I mean, that's huge. And I think what you said, you know, you said then about the physiology of pain that's persisted over a prolonged period of time, that, you know, anything that was wrong for the most part has fixed itself. And that really what's now wrong is the pain interpretation mechanism has gone awry. What did you say? The software, yeah.
The software, yeah.
This is you know, it's a really, but that's a very challenging, you know, a set of circumstances to be presented with, because those signals are so very convincing. You know, we know this, that, you know, people, it feels like there's something wrong, and how can this possibly be right? You know, feeling this way, how can this be right? And that's really hard for lots of people to accept, I suppose, is something that we...
I think a lot of people come to us having been told by GPs and different sort of professionals that their pain is in their mind, it's not real. challenge of sort of explaining that the pain is real. It is a real pain. However, the brain is responding in a way that it's not helpful. You lower the pain threshold because you're getting so many signals, and the brain has to protect you. So it thinks, oh, I should start to notice these signals a bit sooner to try and make sure nothing's going wrong. Therefore, the pain is much more obvious sooner, and then it comes there persistently. And it's about retraining the brain to turn down the volume, so to speak, on those sensations that are coming from the painful part, and turn down the volume a little bit so they're not quite as intrusive. And that's really tricky when you're speaking to patients who have had this pain for a long time, or have been told it's in your mind. It's not really there. It is there, but it's the mind that needs retraining.
I suppose that's the other side of the coin, that either the people are convinced that there's something mechanically wrong that needs fixing, and they're wedded to that idea, or that they have, sadly, somehow been given the impression that there is something wrong with the mind, and that it's them. There's something wrong with them in their mind that is making this happen, which is not the case. Like you say, there's something wrong in the brain, and that's what that's a hard message to sell. It's not in your mind, but it is in your brain.
Yeah.
It just so happens they coexist in your head, in your skull, shall we say. So yeah, that's a difficult one sometimes for people.
And it takes a lot of time actually to get the patient to understand that, we're not disbelieving them, but it is something that needs continuous work and change the thought process, and understanding and accepting what pain is, and how it can be managed better.
I mean, I suppose this is the thing. We're open to the fact that, that physiological processes, because the signals that are short-circuiting, if you like, they're not just electrical signals. They're going to the muscles, and they might create increased muscle tone, and they might, and that's that's something that maybe a massage might help. So that's when it does come down to a package of appropriate interventions, and that's when I think movement in particular, obviously that's my default, my background, it can be so beneficial for people to begin on that journey towards restoring a degree of normality in movement, and removing the fear, the fear that you described.
And I think it's that kind of, it's getting the patient to understand that movement is good, because the less they move, the more the muscles decondition, they become the joints become stiffer, and it's about encouraging people to move. And although my day job is all medicines and morphine and all that kind of stuff, in reality, my true thoughts about pain management is movement and yoga and mindfulness and the meditation and all those kinds of things that are much more beneficial to the body as a whole. And the hands-on therapies like the physio, the massage, TENS machines, all those things that help. It's about building your own little toolkit of things that work for you. So it might be a little bit of medicines, you like the acupuncture or your massage, a little bit of heat packs, sometimes the TENS machine. It's about having a whole range of skills and techniques and resources in your toolkit to be able to manage your pain, manage your flare-ups, depending on how it feels. So it's about lots of different aspects that are personal and individualized, really.
Yeah, that's right. You absolutely. I couldn't agree more. You touched briefly on the medications that we're increasingly becoming aware that medications with the side effects actually can be inappropriate, counterproductive, particularly for people with prolonged pain. That you hear the story of, I take this, I take that, I take the other, and still they have pain. So, and yet the connection is that we need more, rather than actually this isn't working, so we need something else, something different, and that's another difficult one to help people to come to terms with, isn't it, as well?
It's definitely a challenge when you've got a patient that's come for his first assessment and they're on lots and lots of medications and they're sitting in front of you and saying none of it works, so I need you to prescribe me something different. And often there isn't anything different to prescribe. You know, we have 3, maybe 4 nerve painkillers that we use, and then we have, you're basically into your opioids, which we're now not supposed to be prescribing because of the side effects of the long-term harms of opioids in non-cancer and chronic pain. So we're now left with not a lot, and there are not very many nerve pain type presentations that will respond to opioid medication. So we have now a huge cohort of patients who historically have gone through all the basic medications, some of the nerve painkillers. The GPs have been presented with the patient who's still in pain. So the only thing that we know to do is to prescribe something strong, and that is morphine or morphine equivalents. And they will work for a few months before you become tolerant. So then the GP has to increase them and increase them and increase them. And now we're hitting a group of patients who are on ludicrously high levels of morphine or morphine equivalent, who have their health at danger and lots of health risks involved with that, and are still in pain. Yeah. Clearly this pain is not opioid sensitive. So now we have the difficulty of having that conversation with the patient to say, well, I think what we need to do is to wean it and stop it. And that's quite a scary thought when that patient thinks, well, what am I going to take? And I have to sit there and say, nothing. There isn't anything else to take. So it is more about thinking of different approaches, different techniques.
Yeah, different. And it's not just about taking things away from them, but giving things in the place. As you say, a whole tool bag of strategies. And ultimately, there's lots of inspiring stories about people who have made that journey, taken that journey, and and arrived in a place where actually life is so much better on the other side once they get to using more lifestyle measures to manage the situation. And that's not to say life isn't without its ups and downs. I mean, that's the same for all of us, really, isn't it? Invariably, you might experience peaks and troughs, but having the tools at your disposal, and that's, one of the biggest things I feel passionate about is helping people to educating people, informing people, so that it's their decision. It's empowering them to be in charge of their own care, their own health, their own wellness. Because that's so important for people to feel that they have choices, I suppose, as well as
I think as well as choices, it's about, like you say, control. So they are in control of what they choose to do, how they choose to do it, and in control of their pain. Yeah. Because their pain can so often be in control of them. Yeah. There's lots of control that is quite debilitating and stops that patient taking action to be able to help themselves, and they become I wouldn't say victim, but they become at the mercy of their pain, and they can't do anything. And it's about, like you say, empowering them, giving them the information and the choices, and encouraging them to make those behavioural changes in order to take control of their pain and change the way they live to be able to live well with their pain.
Yeah, live well with pain, and maybe some days you won't feel it at all.
Hopefully.
Well, yeah. So you were saying I wrote a blog last week about pain in the brain, didn't I? And this week I went on again. I don't know if you've seen that particular one, but it's around the concepts of danger versus safety. And so this idea that the more danger we feel or think we're in, the more that these sensations will be heightened. And so if we can turn that around so that we put people to a place of safety. So sometimes it's people are concerned that if they move in a particular way, or a particular sensation is is heralding danger, but actually, you know, it's just a normal sensation that your body's misinterpreting perhaps. So giving people permission to, you know, to move for one, and then thinking about everything in the broader context, places, the senses, smells, sights, sounds, what else was there? The way you feel about it, the way you think about it, catch yourself having, you know, negative thoughts perhaps, and turn it on its head somehow. So there's lots of strategies that people can employ to turn that whole thing on its head.
We can talk about the soothing system.
Oh yes, go on.
So you've got your drive system and your threat system and your soothing system. And our drive system, human nature is quite well developed because it gives us that desire to achieve and get better and to pass our exams and to do whatever. The threat system is there to keep us protected and safe, which is what you were saying about that safety, and that's driven by adrenaline. And of course that adrenaline all the time is not good for us, but we're very underdeveloped in our soothing system, which is the system that counteracts the other two. So, you know, whether we do breathing techniques or relaxation or something that you enjoy, that will start to turn that threat and that drive the other way and just calm things down. And that has the beneficial effect of reducing stress, anxiety, pain, experience. Mm-hmm. Most people, we're quite underdeveloped in that soothing system because it's all about and drive, I must achieve. So it's about kind of trying to readdress the balance, really.
Yeah, and I mean, modern life is really taking us down that path as well, isn't it? With, you know, 24-hour lifestyles, technology. I mean, we love it, but you can have too much of a good thing. Yeah, so soothing, that's interesting. We're not as well developed at that. And so actually we need to practice these skills, don't we? It's a skill and an art like any other. And that's, you don't need to tell us because we're training to be yoga teachers. So
we're learning that.
We're obviously loving that, yeah. Oh, well, I say you don't need to tell us. Actually, everybody stands to learn and practice is the thing that we all find ourselves not making the time for these things that we know. You know, I know, you and I know that deep breathing and meditation is good for us, but finding the time we're all guilty of not making the time for our own selves, aren't we? And so
yeah, and particularly when you've got lots of things going on, you know what you need to be doing, that you just haven't, you know, you look at the time and think, oh, I haven't made the sandwiches or been to the wherever I'm going and finished work and done all the bits and pieces. And actually, if you did do it, then you would feel a lot better. So it's about trying to have that balance, and none of us are very good at that, I don't think.
No, we're not. Yeah, and so
drive system, isn't it?
It is. So it really comes down for me. I, you know, talk about it, making it so much part of what you do, your routine, that you almost do it without thinking about it. You don't have to plan it. You've planned ahead. You've made a slot in your day when this is going to happen, and you know, whatever it is, whether it's movement, whether it's meditation, whether it's just listening to music, you know. You've made that time in your day when this is definitely going to happen.
Yeah, try.
We try. Well, you know, and then at least if maybe 5 out of 7 you might get there. Or the 80-20 rule.
Yeah, definitely. And it's, you know, I think that's the same thing with everything, isn't it? If you really want it enough, you will, and you know, you do make time for the things that are important. And it's
put it higher on that list. On that list.
we need to make ourselves a priority more so than what, you know, and our own physical and mental health, really. And once you start to put those things in place, then I think everything will start to improve.
Yeah, no, absolutely, definitely. So I might have mentioned to you that I have got a particular interest in helping people, women, of course, menopausal women. Mainly because I am one, and I've been on a bit of a journey the last few years with my perimenopause, And so one of the symptoms associated with this, the hormonal shift, is joint pains, and you know, generally people feeling stiffer, achier, and so we know this is associated with the drop in estrogen levels. But well, we know this, but there's lots of people who don't realise that joint aches and pains can be part of this perimenopause and menopause transition. And I think often it's worse in the transition, and then maybe you get through it, and the other side is not quite as bad. But you know, I kind of sometimes worry, I say worry, I think that people who have pain often make changes in the way that they move the bodies, in the way that they use the bodies, because especially if you can't think why you've got a pain, you know, I didn't do anything. All it is, you know, I get out of bed in the morning and whatever, or I was getting achy fingers and toes, which, you know, kind of weirdly. And, you know, but I knew this is what it was. And so it kind of didn't, I mean, it bothers you, but it didn't bother me. I didn't think there was anything seriously wrong with me. I just knew that this was what it was. But I think for people who are not expecting that, for people who are not knowing that this is part of what's happening in the bodies for women, and then we start to do the strategy of avoidance, which is our default strategy. You know, the you know, what we were saying about the threat. The best way to be safe is to avoid it at all cost, isn't it? And so then people start, as you mentioned, to become physically deconditioned because they're not maybe doing all the things that they did, and then you maybe start to feel resigned to this future of not being able to being stiff, or not being able to lift heavy things, or you know what I mean. And I just don't want that for people, because I don't think we have to go down that route. You know, you and I'm no spring chicken. I'm not. I can't remember whether we're similar in that or not, Lou. But you know, I think that the stronger we are as we go through this, you know, future existence, the better, the healthier we're going to be ultimately, aren't we? So,
yeah.
How do we?
I think it is about kind of understanding those kinds of changes and acknowledging the fact that they're not anything to be scared of or to be worried about. They are sort of normal, and learn to adapt and like you say, keep moving, because that's when you've got that threat, and the body will sort of back off and make you rest if you're feeling a bit sore. And actually resting is probably not the thing that needs to be done. It needs to build the muscle strength. And you know, for osteoporosis, we need to make sure that the bone, you know, the impact kind of exercise is there to maintain that bone strength and to maintain the muscle intensity, because the muscles will protect to a degree, and you know, so it all has that sort of knock-on effect. But I think if you aren't aware that these symptoms may be potentially menopausal, then you start to worry about other things. And like you say, it's having that knowledge to understand what all these changes are, what the symptoms are, and work through that to sort of come out the other side without having become a recluse and not moved anywhere or anything at all.
I mean, that was entirely possible at one stage, but not because of my joints. So the other thing is, people self-medicate, don't they, when maybe it's just a bit of an ache, and that's an interesting, I think there was a program on the television about the extent to which some people self-medicate. It was one of good old, what's his name, Dr. Oh, you know who I mean?
Yeah, does lots of research things, doesn't it?
Yes, yeah. Oh gosh.
Mosley,
Michael Mosley.
somebody Mosley, yeah.
Yeah, he did a program on the television where they went to a garden centre, I think, and there were all these different members of staff, and they did a survey of who was taking just over-the-counter type medications, Brufen and paracetamol and all that, and there were some people who were self-medicating like ridiculous amounts of medication, and of course they've never even been to the doctors, some of these people. And they did this, you know, they went through a whole raft of strategies to help people have less pain. One of them was exercise, and the other one, guess what? Did you see that program?
I don't think I did, no.
The other one was singing.
Singing, okay.
Yes, singing. So then they gave them these interventions, and they had to do it. I think it was something like once a week for so many weeks, 8 weeks, whatever, 12 weeks. And then they evaluated at the end how many tablets each individual was taking at that point, and everybody, pretty much without fail, was taking less of this self-medication. You know, and that's, some of that is not such a great idea, is it? You know, to be
not the self-medicating. I think if you found singing is more beneficial, you know, I had a patient once who said to me the only time he doesn't have pain is when he's playing table tennis, and he was in his 80s. And so I said to him, do you think it's because there's no pain when you're playing table tennis, or do you think you are enjoying yourself and what you're feeling is elation and that you feel good, and actually the pain is not at the forefront of your brain? And I think that's the same with lots of other things. It's about you know, how the brain is interpreting what you're doing, and that feel good factor, the thing that you really enjoy, is what is the overriding feeling.
Yeah, joy, definitely something that shifts the frame of mind towards the positive, or the and distraction as well, isn't it? Some of it is just purely, you can't think about that when you're, you know, looking for the table tennis.
Yeah, and it's about doing the thing that you enjoy, the thing that
doing the thing you enjoy. Yeah,
far better than self-medication, because you get so many weird stories about what people are trying and who they've borrowed their tablets off, and who they've tried this so-and-so's pills from the cupboard from where you think, oh, you know, I'm taking 24 paracetamols.
We might have all been guilty of that at some point, but yeah, it's not a great plan, is it? Really, certainly not in the long term.
Now, buying things off the internet, you worry really that, you know, people are desperate, but sometimes it's the simpler things that we need to look at.
Well, it's not policed well, is it? You know, it could be anything. It could be, I mean, it could be something totally made of chalk and nothing else, but equally it could be harmful. So we're not recommending that by any stretch of the imagination, are we?
No. Table tennis and yoga might be the best options.
There you go. And Pilates, don't forget.
Pilates, of course, yes.
You could even sing while you're doing it. There you go.
Oh, you could, yeah.
Sometimes. Yeah, people laugh at me when I sing the odd refrain. But, thank you so much for giving your time. It's really wonderful and kind of you to...
It's my pleasure. It's been really interesting.
Yeah, thank you so much. And I'll be seeing you again for the next yoga week.
Yep, next weekend, I think, isn't it?
Yeah, next weekend. So thank you again so much for your time, and I'll speak to you again soon. Thank you.
Thank you.